Hey guys, today I'm excited to have Dr. April Staples back with me. We had an episode a while back about raising your kids after deconstruction. So if you want to go back and listen to that, but you want to give your little intro again for those who didn't listen
Sure.
to the episode.
Yeah, absolutely. So I'm Dr. April Staples. I'm currently a provisionally licensed psychologist here in Texas, and I work with a variety of populations, primarily doing diagnosing um, and a little bit of therapy. So that's me.
Great,
Yeah.
yeah. So I thought today we'd talk about mental illness and psychology at large. And me and April were both diagnosed with ADHD at some point. So I thought we'd kind of tell our story growing up, what that was like. If you want to go ahead and start.
Yeah, sure. So I actually wasn't diagnosed with ADHD until later in life, as I was going through graduate school. And for me, it kind of fits the idea that tend to be diagnosed a
Mm,
lot later than boys, and a lot of that is because our expression of the illness is a little bit different. Boys tend to be a little more rambunctious and a little more outward, have a lot more outward behavior that is more noticed by teachers. Girls still have that outward behavior, but it tends to emerge as more like helping behavior. So, like, can I help you erase the board? Can I help you pick up the crayons? Can I getting up out of your seat and
hmm
just trying to be helpful kind of thing.
mm.
Um, and
Yeah,
so
that isn't it. Like guys tend to be ADHD and girls tend to be ADD. So like the hyperactive isn't as prevalent
yeah,
in
I think
women.
I don't yeah, I couldn't say like offhand what the differences in percentages are, but I know that the hyperactivity that in boys and girls is presented differently.
Mm,
So you might
hmm
see hyperactivity in girls, but you might not identify it as a problem behavior
hmm
because they're being helpful.
mm,
They're like
got it.
cleaning up the classroom,
hmm
right? Versus like disrupting other kids and throwing their chairs or, throwing toys
hmm
everywhere or
hmm
dumping out crayons, whatever. So it gets overlooked for a long time because they tend to engage in more, I hate to, more socially
Right,
acceptable
right.
kind of
hmm
behaviors. And then if you are just the inattentive type, you don't have the hyperactivity, then you definitely aren't really going to get noticed at all because you're
hmm
just kind of zoning out. You're in your
hmm
own head and you're not bothering anybody.
hmm
And so they can kind of fly under the radar for a long time. For me, um, my intelligence helped me to do well in school,
mm
even though I really struggled with keeping track of paperwork,
hmm
keeping track of my homework, knowing, where to turn things in.
hmm
um, but on test day, I was smart enough that I could do well enough to pass the class.
hmm
And so I never studied for anything ever. I would just never took any
hmm
notes.
I
I
studied,
just
but it
never
was
showed.
always like last minute because my long term memory
Yeah.
was just not there.
Yeah, exactly. It was like more cramming. It was
hmm
like pulling all nighters, a lot of procrastination, a lot of,
hmm
waiting till the last minute. And, always in school, it was like, I was smart enough to hang out with like the group of kids that were considered the smart kids.
hmm
But then also there was always a part of me that was like, why can't I keep up with them? Like, I
mm
feel like I should be able to like do the things that they're doing. And I never realized that it was because I had this executive functioning difficulty where they could sit down and study and keep track of their paperwork and they could read something and not like start wandering off in the middle while they're reading their
hmm
textbook and be like, oh my gosh, what did I just
hmm
read? And then have to read it again. Oh my gosh, what did I just read?
For
And
me, it was funny when I read out loud. I read really fast when I read just to myself, and so my brain starts to read ahead, and then I'm trying to say it slower and then I can get garbled. And that's the same thing when I'm writing. I'm thinking ahead. And so then my hand starts trying to write letters that are ahead of where I'm at. And it's just looks like a
Gotcha.
mess.
Yeah. And then before you know it, you're tripping over yourself.
Right.
And
Exactly.
yeah. But so in school, that's, that's what it was like. It was difficult to stay on top of things. I knew I wanted to go to college. And so, because I grew up on the reservation and I just really wanted to get off the reservation. I was like, this is my way to leave and experience something different. So this was like my ticket. So I had a good motivation to like try, but it was still really hard. And, some of the silly things that I did that, now looking back, I'm like, oh yeah, that was totally my ADHD. Like, I don't know how many times my dad had to come jump my car because I left my car lights on when I would drive to school, losing my keys, just forgetting appointments, showing up late, not having any kind of like time, like understanding of time. It was like, this time blindness just constantly, was after me. So when I got into my doctorate program, I was able to do pretty much the same thing through my undergrad and my master's degree, where I could write I could pull an all-nighter and write a 10-page paper, and it was fine. And then once I got to, my doctorate program, and really getting into writing my dissertation, it was like, okay, well, you have like 10 years to finish this if you need to. And I'm like, oh no, like this is never, this is never going to get done. And then it was like this mountain that all I could see were all of these pieces that I had to put together. Like, okay, we want you to develop research questions and methodology. What's your methodology? And you need to go through all this literature. And it was just a lot. And then while you're trying to plan, which your brain struggles with if you have ADHD, is like knowing where to start. You just get into this paralysis. You
have a hard time breaking things down, right?
Yeah. And so at that point I was like, something is wrong. Like I cannot compel myself to do this task. So I went and I got tested by, a psychologist, and they're like, yeah, I definitely have ADHD based on your history and, what I was experiencing. So I ended up getting on meds. They put me on a really low dose of Adderall. And I remember the first time I took it, I was like, oh, like I can actually like read an email without like getting distracted in the middle of it. And, keeping track of things that I needed to get done, and just my executive functioning in general, it became clear how much of a problem my executive functioning was prior, because I have 3 kids and, I'm also working teaching, and I started to lose my ability to manage like my laundry and make sure I had groceries in the refrigerator, and what am I going to cook for dinner, and never having gas in my car, and forgetting to pay this bill or forgetting to go on that appointment. And so your daily living becomes unmanageable. So at that point, I realized why. So it's been life-changing. I mean, it's completely helped me, one, to have more grace towards myself when I recognize that I'm overstimulated, that I need to take a step back, and mostly knowing when I need to ask for help. I'm a very hyper independent person.
Right.
And I think for me, like the biggest awareness I had was like, you need to ask for help. If you need help, you got to ask for help. So I definitely am lucky to have, my husband, who I always call him like he's part of my executive functioning, just reminding me, like he'll put gas in my car because he knows I'll forget, things like that. So that's kind of like my journey in terms of getting my diagnosis. It was later, which, is not surprising either, being somebody from the reservation, indigenous person. I'm 39. So at that point in time, it was not something that
wasn't
was
as big
necessarily. Yeah. And it wasn't really believed to be a real condition. It was a lot of it was like, it's just a bratty kid. Only bratty kids, have that condition. And so, yeah.
Did you get like flack from teachers or your parents? And did that mess with your self-image?
After I got the diagnosis,
No, before, just like
or
growing up, struggling, and to some extent.
yeah, yeah. I think the interesting thing is ADHD and neurodivergency is really has a huge genetic component to it. And so I'm pretty sure my mom, she has undiagnosed ADHD. So she had a lot of the same kind of behaviors and things like that, difficulty keeping track, sometimes. And so thankfully, my parents were very understanding and accommodating. They really didn't give me a hard time about struggling when I was struggling. They were like, just do your best. You're doing the best you can. They could tell that I was trying. They knew I wanted to go to college. And so thankfully from them, I really didn't experience a lot of negative interaction regarding my performance or anything like that.
Mm.
But it definitely was like, why do you have a difficult time with turning your lights off on your car? Why do you keep losing your keys or breaking your glasses or things like that? But wasn't anything that negatively impacted my self-esteem or anything, thankfully, like that. Yeah,
That's good.
yeah. So tell me a little bit about you were diagnosed like earlier, right?
No, actually, it was in college, so maybe it's like slightly younger, but yeah, it was still pretty late. So when I was young, my mom, she babysat a bunch of kids, and I think I enjoyed that. But after a while, I think it overstimulated me, and then like throw a fit or something, it would just be too much energy. And my mom didn't understand that, and I would get spanking and stuff like that. So I think that was like the start of it. But then I was homeschooled actually, but I really struggled just like sitting still. My mom actually got me like one of those old school like desks. It's just really heavy, and it was still like throw myself out of that. Like it was a big struggle. And then I struggled actually learning to read, but then I took like, what was it, a Beck or something like that, and it was like really hard. But once I learned, then it's like I hyper focus on that. Like I got into reading and I loved it, which is very unusual for kids who have ADHD actually. And I think like you said, I think my intelligence definitely helped me get by. And and then I started going to private school, but the private school was only, you go 2 days a week and you have homeschool 3 days. So it was kind of like a slow process. And then in high school, I started going to public school. So I slowly got simulated into 5 days a week, 8 hours of school.
Right.
But in junior high, I was super unorganized. And even I had to learn in high school to get more organized, because I would just like stuff all my papers in my backpack and they wouldn't be like in their binders. And I would forget like assignments and when they're due and all that stuff. And what I enjoyed, I could focus on, but what I didn't enjoy, it was really hard to focus.
I was, I loved music so much. I was always, my grandfather's musician, and then I started playing music in church, growing up, learning how to play all the instruments. And so I knew when I went to get my undergrad that I wanted to at least have a music minor. And I loved the music part of it, getting to play the guitar, getting to play the piano, but a requirement of the program was you had to do ear training. And ear training is where you hear a melody and you have to write it down on a piece of paper just by hearing it.
Oh, wow.
And the only way to really get good at that is just to listen to intervals, music intervals, a lot. I mean, it's just a lot of practice.
It's like a lot of repetitive.
Just repetitive. And I failed that class, I think, like 3 times because I just like could not get my brain to want to do it. I just didn't want to do it. And nothing, even though I knew I needed to do it and I wanted to, there's just no dopamine involved. There was no joy. And my brain said, nope, we're not doing it. So I was one class short of getting a minor in music because I couldn't finish that class. Yeah.
What I've noticed about myself, and maybe this is an ADHD thing, but I'm a big picture person rather than like detail person. And details, it's just really hard for me to focus and get into as much. And yeah, the imagination, the creativity. So like I was really into English. History was pretty cool. But like science, it was no details, and it didn't feel
Yeah.
creative to me. And math was okay. I liked it to some degree, but it wasn't huge into it. But yeah, more like stories and the psychology and the
Mhm.
imagination, that kind of stuff. That's what really drew me in.
Yeah, 100%. And I think, I've it's interesting with neurodivergent people. I think we almost have this beacon that draws us to each other, where it's like we get this sense of like, oh, I think you're one of me.
You're
I
one of
think
us.
you're
Mm-hmm.
one of us. I found that most of my friends are neurodivergent without even like
Mm-hmm.
recognizing that we were kind of connecting because our
Mm-hmm.
experiences were similar. And we tend to all be very connected to spirituality, connected to creativity,
Mm-hmm.
so different forms of expressing that. I have
Mm-hmm.
friends who are artists and photographers and singers and musicians, and they just seem to be a little more connected to that creative interconnectedness
Mm-hmm.
part of their brains. And
Mm-hmm.
so I've often wondered, like, I wonder if neurodivergency, people with the neurodivergence, they just have such a strong sensory experience that I
Mm-hmm.
feel like makes me feel more connected to God, to like the energy in the universe, or
Mm-hmm.
like something bigger than myself. It's like
Mm-hmm.
I can feel music in my body.
Mm-hmm.
And to me, it was always a way for me to connect to God. Was like, man, this is something, I don't know how to describe this feeling of
Mm-hmm.
like feeling vibration in my body. It's like I
Mm.
can feel warmth. I
Right.
feel like to a different degree when I'm out in the
Mm-hmm.
sun. And I can taste food differently because my
Mm.
sensory experience is like very heightened compared
Mm-hmm.
to a lot of people who aren't neurodivergent. And
Mm-hmm.
I feel like that made me more connected to like the unseen, you know, realm of things
Mm-hmm.
uh, that are happening. So
Do you feel like non-divergent, neurodivergent people, could they perhaps be experiencing it as extreme? They're just not as expressive about it.
I don't know. I think that's a good question. Like my husband is like almost like a science project to me because he's not neurodivergent. And so I'm
uh-huh.
always just observing him like in his world. I
Mm-hmm.
remember one time I asked him like, what are you thinking? I think we're just, he was just being really quiet. He just wasn't
Mm-hmm.
saying anything. He's like,
Mm-hmm.
he's introverted. But I was just like, what are you thinking about? And he's like, oh, nothing. And I'm like, what do you mean?
Mm-hmm. I think there's always a meme
Like,
about like girls versus guys, but I
yeah,
feel like I'm always thinking about something too.
yeah. And he's like, oh, I'm just not thinking about anything. I'm just, looking out at the yard,
Mm-hmm.
looking at the sky.
Mm-hmm.
Um, and it was just like mind blown to me that like he has these periods of like just being,
Mm-hmm.
just the experience of being, where it's not
Mm-hmm.
trying to answer a question
Mm-hmm.
or thinking through these really deep topics.
Mm-hmm.
It's like he just can experience, but he also doesn't seem to express his experience as openly or as deeply, I think, as a lot of people who are around me. Obviously, this is all anecdotal
Mm-hmm.
people I've been around, but
Right.
it feels like people who are more neurodivergent tend to be able to express
Uh-huh.
their emotional experiences
Mm-hmm.
a little more
I think
freely.
it's like it's almost like a survival thing. It's like because my brain felt like chaos and a lot of emotions, a lot of thought. I needed to be able to learn to process and observe these things so and make sense of them so that I could function. And so
Yeah,
that helps us then be able to express it better and think about it more maybe than non neurodivergent people, perhaps.
yeah, yeah. Yeah, I think that's true. I think it's just difficult. We just never know what somebody's, phenomenal experience is, right?
Mm,
Their lived experience, what it's like to taste, touch, smell,
mm,
see, hear. We just are never going to know what that's like for another
right.
person.
Mm-hmm.
They have to tell us what
Mm-hmm.
that's like for them.
But it's also
And
it's awesome. It's like we're all experiencing the world in different ways.
yeah, very, very different ways.
Mm-hmm.
So
But similar
even my
too.
husband, yeah, even my husband will tell me, he's like, you feel so deeply, like
Mm-hmm.
you care so deeply, you feel so deeply, and you see that in a lot of neurodivergent. When you look at children, children who are neurodivergent, they have a big emotional reaction. They have big emotions.
Mm-hmm.
They get angry maybe really quickly, or they get
Mm-hmm.
excited. They also get happy and excited really quickly. So their emotional regulation can
Mm-hmm.
be difficult to manage
Mm-hmm.
sometimes, and bringing it back down can be difficult. Regulating it can be
Mm-hmm.
difficult.
Mm-hmm.
So it feels like they experience emotions to a
Right.
greater degree than people who
Mm-hmm.
can regulate it a little bit
Mm-hmm.
better, you know?
Mm-hmm.
Yeah.
Yeah. Well, speaking of ADHD, back
Yeah.
to my story.
Yeah.
No, that was great. But yeah, college is I it was my senior year, and I had a big research project, kind of like what you're saying. Well, I mean, not to that same degree, because I've been to grad school and I know how much bigger it gets, the projects and stuff like that. But um, for me at that time, it was a lot, and I kind of got into that freeze and that procrastination, and I had so much anxiety, and I even developed like a shake in my hands, like I was at a bad state, and so I started going to counseling to try to manage that, and but I also got diagnosed with ADHD, and I started with Ritalin, but I didn't like the way that it made me feel, so I did start taking Adderall, and
Mm.
I did think it helped some, but it was kind of weird. I felt like a lot of times I struggle with energy. It's like I had a lot of energy, but I was like burning a lot because I was like thinking and feeling so much. I think it was like using so much energy. So I felt exhausted a lot. And I feel like that was part of why it was hard for me to focus. And so I felt like the
Right.
Adderall gave me more energy, and then I could focus because of that. Not that it
Hmm.
necessarily made me more focused on its own, if that makes any sense.
No, it makes perfect sense. Yeah. I think that leads us, it's a good segue into the conversation we want to have today, which is really about DSM, and
Mm-hmm.
diagnosing. And for those who aren't familiar with what the DSM is, it's our Diagnostic and Statistical Manual of Mental Health Disorders, and it's the primary text that we use. I don't even know if we call it a text, but it's it's the book
Manual.
that we
Yeah.
use,
Yeah.
the manual that we use to diagnose and really, file insurance for people who are getting treatment. And so that kind of leads a good segue into medication, right?
Mm-hmm.
You started off with one, and then tried another one. You felt like, it helped you a little bit. I started off with Adderall, extended release, a
Mm-hmm.
small dose, the smallest dose, that they have. And that helped me. And then they increased it just a little bit, still a low dose, like 10 milligrams, very
Mm-hmm.
low.
I think I was doing
And that was,
20.
yeah, and that was enough for me to,
Mm-hmm.
to be able to, get some help. But the thing with, and one of the criticisms you'll hear about ADHD, because there's a lot of people right now who, there seems to be two camps. There's like the anti-psychiatry psychology camp, who are like
Mm-hmm.
anti-diagnoses, anti-medication, and then there's the other camp, I guess, that maybe
Mm-hmm.
encompasses everybody that's not anti. But uh, Adderall and all of Vyvanse and Ritalin, they're going to show improvement for most people, even in people who don't have ADHD. So that one of the criticism is uh, anybody can take it, and they're going to
Mm-hmm.
report feeling better because
Mm-hmm.
it's a stimulant that's
Mm-hmm.
going to give you energy, that's going to make you feel focused, even if you don't have ADHD. And
Mm-hmm.
so this is where yeah, that can be true, that it is going to make everybody else feel better.
Mm-hmm.
We also have to
But
listen
it'll
to
also
each
have
other.
extreme reactions. Like my brother said, he took a pill once because he
Yeah,
had like a big project.
right.
Um, I think it'd be fine with me saying this, but
Yeah,
but he's like, I didn't eat, I wasn't hungry, I was super annoyed if anybody interrupted me, and I stayed up like all night. It was
yeah,
just
yeah.
like just doing my work.
Right. And there are yeah, for sure. For some people, the stimulant's just going to make them really agitated, really
Mm,
uncomfortable, really, heart palpitations, stuff like that. But it's one of those things where when it comes to medications, one, that's why we go to a psychiatrist who is trained on how to navigate managing these medications and how much of the medications and changing the medications. Because really, at the end of the day, we can't give each individual patient a blood test to determine what medication is
mm-hmm,
going to work best for
mm-hmm.
their neurotransmitters, right? For
Right.
we don't really know what brain, chemicals need to be adjusted in your particular brain. And
Mm-hmm,
so it does come down to, let's give this a try and
mm-hmm,
see if it improves your daily living. And if it doesn't, let's talk about it and follow up, and we'll readjust, and let's talk
mm-hmm,
about it and follow up. So getting a doctor that you're comfortable having these conversations with so that you can make adjustments, that's really what you're looking for. It's
mm-hmm,
rare that you're going to say, okay, well, I'm going to get on these meds and it's going to make me feel better, and that's the end of the story.
mm-hmm.
You know,
Yeah.
it's a complicated process.
Right. I think it's been cool to learn a little bit about neuroscience, and neuroscience is kind of we learned a lot more, and it's risen in popularity. I guess what I'm trying to say, but it kind of goes with the materialism, physicalist mindset
Mm-hmm.
versus not, and just that like we can understand, and also like our identity, who we are, is based on like our brain and our brain chemicals. But I think you and I are both on the camp of it's more complicated than that. We can't understand, and it's more diversity and uniqueness and a lot of things we don't understand. So not everything can be boiled down to like a chemical mathematical equation that can understand us.
Right. So it's the difference between having this kind of deterministic kind of
Right.
view of humans where it's like, well, if you have this much dopamine or this much serotonin or this much oxytocin, then you're going to have this experience.
Mm-hmm.
We just, we don't know that.
Mm-hmm.
Because everybody's experience is so different. I like to think about our brain chemicals in terms of, I think the best way to understand it is like love. So even though we know what chemicals are involved in bonding, like what
Mm,
neurotransmitters are involved in bonding, humans bonding, right? Um, just because we know that, it doesn't make the experience of love any less meaningful or valuable or, um, you know, transcendent.
mm-hmm.
And so knowledge about these chemicals and how they contribute to our emotions doesn't negate the reality and the impact of those emotions.
Mm-hmm.
And so I think that's a really important thing is like, you know, some people like to want to ignore the science of, well, no, it's not just this chemical or it's not just that chemical. Well, it's both, right?
Mm-hmm.
it's
Mm-hmm.
it's the chemical, and then it's our assessment or our evaluation of what that feels like. Like there's
Mm-hmm.
something there that tells us this feels good, and we like it, and
Mm-hmm.
we want to keep hanging out with this person or keep doing this thing or
Mm-hmm.
whatever that might be. But sometimes those brain chemicals can, we can get too much of them or too little of
Mm-hmm.
them,
Mm-hmm.
and we need medication to help manage that so that our daily experiences are not difficult,
Mm-hmm.
you know.
Right.
Um,
Yeah, I think a good way to think about it is kind of a both and. So,
yes.
obviously our brain chemicals affect us and they can be off, and we can take meds or take vitamins or whatever, do things to alter those chemicals. But also, I think that, our thoughts and emotions, we can work with those and, do like therapy as well to
Mm-hmm.
that will alter these chemicals naturally in that way.
Correct.
Yeah.
Yeah. And there's some people who can increase the amount of dopamine that they have by doing things like working out or
Mm-hmm.
hanging out with friends, or and
Sunlight.
they're
Yeah.
right.
Mm-hmm.
Sunlight,
Mm-hmm.
getting in, ice water, right? Doing an ice bath or cold
Mm-hmm.
water, but their baseline level of dopamine is going to be higher than somebody who has a mental health condition where their baseline dopamine is a lot lower. So
Mm-hmm.
even if they do get in the sunlight and they do get in cold water and they do
Mm-hmm.
everything right, they do all these behaviors that everybody
Right.
tells them to do, they're still going to not feel good
Mm-hmm.
because
Mm-hmm.
it's still not bringing that chemical, that dopamine up, or
Mm-hmm.
whatever chemical they need to bring up. It's not bringing it up to a level that is going to help them to function every day.
Mm-hmm.
So we see that with, for example, there's depression that is treatment resistant, right? It's like no matter what this
Mm-hmm.
person does, even with medication, even with changing their lifestyle, no matter what they do, they can't get their brain chemicals to a baseline that's going to allow them to feel
Mm-hmm.
good, to feel
Right.
better. And
Mm-hmm.
so, there's a lot of different things that treatment options for the non-resistant or the treatment
Mm-hmm.
resistant depression,
Mm-hmm.
um, but it's not as simple as just doing meditation or
Mm-hmm.
working out or going for
Mm-hmm.
a walk or,
Yeah. I think that's
that.
where the spiritual part comes. Like psychology is great and it's helpful, but the spiritual part too. If someone doesn't have a reason for living, then it doesn't matter what they're going to do. It's not going to
Yeah.
help. So
Yeah.
you could talk about like Maslow's hierarchy of needs, the self transcendence, or just yeah,
Yeah.
all those things are very important and impact everything else.
hmm So when we think about mental health conditions, we want to think about them not as just chemicals, not just as biological, but we also want to think about the social determinants, right? Also, what kind of environment is this person living in? What kind of people
Mm-hmm.
is this person surrounding themselves with? What kind of content are they consuming? Is it making them feel worse? If you're watching the news every single day,
Right.
right? I mean, that's going to make you feel pretty bad.
Mm-hmm.
um,
Mm-hmm.
and so, our mental health conditions really, you want to look at multiple areas of
Angles.
experience.
Mm-hmm.
You got to look at the biology, of course. You want to look at the social interactions and then the individual psychology. So your individual thoughts and
Mm-hmm.
experience of your environment, of what you're experiencing. How do you make meaning out of that experience? So, perfect example, if you look at schizophrenia, for example, we do know that schizophrenia has a very high correlation. It's related to your genetics, right? For many people,
Mm-hmm.
if you have schizophrenia, it's very likely that somebody else in your family also experienced it. So we've been able to correlate that with a lot of biology, but we also know that your relationships with your parents have a huge impact on that, or your social,
Mm-hmm.
interactions have a huge
Mm-hmm.
experience, impact on the likelihood that you'll develop it and how serious it's going to be, how many symptoms you're going to experience, things like that.
Mm-hmm.
So those all interact together to determine how you're going to experience schizophrenia. And
Mm-hmm.
so you might have a biological predisposition to get schizophrenia, but then you have a great relationship with your parents. They're supportive, they're helping you with your treatment management, and the way you think about it, your individual psychology is you've learned to think about your hallucinations, auditory or visual, in a positive way. So you're not distressed when you have them. You're
Mm-hmm.
thinking about them in, maybe they're helpful,
That's what I was going to say.
auditory and hallucinations.
Mm-hmm.
And so these people, if that's the experience where all three of these factors are positive, that
Mm-hmm.
person's probably going to be fine and have a positive
Mm-hmm.
experience.
Yeah, I think so much, and I haven't thought out a good way of saying this, so I'm going to do my best. But just
Yeah.
what comes into how we translate what's in our body, how we feel that, how we think about that. Just like my old counselor would always say, excitement and anxiety is the same jittery feeling in the body. And so it's how we interpret that makes it helpful or harmful for us. And so if we can recognize that and learn to recognize how we're interpreting it, and then work with that to change that over time, if possible.
No, I think that's exactly it. So, for example, and when psychologists or therapists say, I want you to feel it where do you feel it in your body?
Mm-hmm.
Right. And you hear that a lot, like you need to feel your emotion. Well, nobody really describes what that means, but it's exactly what you're saying. It's, am I experiencing like a rapid heartbeat? Am I experiencing like, like a little bit of my stomach dropping, where I kind of feel like, oh, I'm a little embarrassed, and how am I interpreting that feeling? So you will feel these physiological changes in your body. And when you can recognize those changes and what they're connected to, then you can interpret what those mean. So like you said, excitement and fear will have very similar physiological expressions in the body. It's both going to have like a racing heart. It's going to be adrenaline for both, right? So adrenaline is going to lead to the same body reactions, but your assessment or your perception of those body, reactions are going to be dependent on the environment that you're in and what you're experiencing. But sometimes it's very confusing, because if you could be sitting somewhere and suddenly you're having like a racing heart and your palms are getting sweaty, you're having all this adrenaline, but there's nothing going on. And then we might call that a panic attack, right? And so being really aware of your body states and what does it feel like when I'm relaxed? What does it feel like when I'm hungry? What does it feel like when I'm tired? What does it feel like when I'm excited? That can help give you some good information for what you're experiencing emotionally. So a lot of times you could feel like you're angry, but you're really hungry, And so it's like, oh, okay, I'm not actually angry right now. I actually just need to eat because my blood sugar is low. And I think a lot of people don't have a good handle on what their internal experiences are
right.
like.
Yeah. I think that, well, I appreciate psychology that I think that they've improved a lot in becoming aware of the somatic elements, and importance of, and then practices. I think that, we talked about earlier before the episode, talking about multiculturalism and the Eastern perspective. And so like, yoga and meditation and these different things to get in touch with the body. That's all become, and I think like EDMR is a common psychology, a practice that is a part of that. And so, talk therapy is important and it's helpful and it's good, and I benefited from it. But also the first thing that I did when I got in therapy was learn meditation, and that helped me get in touch with my body and deal with my anxiety and come back down to the earth.
Right. So a lot of the more somatic therapies where you're tuning in, you're becoming embodied, right? You're tuning into what's happening with your body. That my dissertation was focused on indigenous mental health. And one of the things we see with the indigenous population is a lot of dissociation. And they experience high levels of dissociation because of so much trauma. There's a lot of intergenerational trauma that's being experienced. So a lot of violence, domestic violence, substance abuse. And so a lot of the people are exposed to traumatic events throughout their lives, and the way that many of them cope, like any other population, most people who experience trauma will dissociate to survive. What happens though is there's kind of this, persistent state of dissociation. And so the treatment for a lot of people in trauma is somatic work. It's
Mm-hmm.
let me teach you how to breathe and how to calm your nervous system down, how to regulate your nervous system, and try to get you used to what that feels like. Because when your nervous system is in a state of heightened reactivity, like it's in fight or flight all the time, you're not going to really be comfortable in a relaxed state. Once you get into a relaxed state, that's going to feel very uncomfortable because you're
Mm-hmm.
not used to it. So a lot of the therapy for a lot of people who have experienced trauma is let's learn how to get comfortable with being in a regulated nervous system state. And
Mm-hmm.
like you said, I agree. Yoga is a amazing practice for getting yoked to the body, which is what yoga means, right? Being embodied, getting used to breathing, being in these, different positions, and
Mm-hmm.
identifying where am I feeling pain, where am I feeling discomfort, where am I feeling relaxed, at what point do I feel my body relax. And so talk therapy really isn't necessarily the best route to go when you're first getting therapy for trauma, really intense
Mm-hmm.
trauma. A lot of it is let's get you back in tune with what's happening in your body.
Mm-hmm. Right. I'll start a question about ADHD. What do you think some of the causes are? Do you know what, Gabor Mate?
Yeah,
I know
yeah,
he's
yeah.
like really controversial, so I think his
Yeah.
take is that it has a lot to do with trauma. What do you think about that?
Mm. Well, I think that there is a lot of research that really demonstrates that it is a a neurodevelopmental condition, which means the wiring of the brain
Mm,
is different.
mm-hmm,
It is divergent from the norm. So
mm-hmm. So like
now we
more than
r-
nurture,
right. And as far as nature versus nurture, I don't want to be deterministic about it and
right?
say that, if you have this gene, then for sure X, Y, and Z. But there are certain genes that predispose us to experience our sensory experience in a certain way.
Mm,
So if you are more predisposed to be sensitive to light and sound and touch and taste, then
mm-hmm,
you're going to react to that appropriately, and that's going to wire your brain in a specific way. Now, if somebody is in a traumatic situation as a child and they aren't predisposed to, uh, ADHD, they can also wire their brains in the same way as somebody who has ADHD, who
mm-hmm,
was born with that genetic predisposition.
mm-hmm,
So it's always both and, right? There
mm-hmm,
are people who have a genetic predisposition to neurodivergency, and there are people who grow up in probably very traumatic childhood experiences where there's adults yelling or gunshots going off, or
mm-hmm,
there's a lot of instability in their environment, and so they react to those environments accordingly,
mm-hmm,
and then their brain wires things like hypervigilance and distractibility, and it has a difficult time with executive functioning
mm-hmm,
because the environment that they grew up in, that their brain was developing in, was chaotic.
mm-hmm,
And so the treatment for both of those people will be the same, right?
mm-hmm,
And somebody who grows up in that environment and displays the same symptoms as somebody who maybe has a genetic predisposition, we're not going to know the difference. We're not going to be able to untangle that. It's impossible
mm-hmm,
to untangle. But I think it's safe to say that, yeah, there's probably some people who it is really just PTSD, that is uh, showing those symptoms. And there are some people who really are born with that genetic
mm-hmm,
predisposition, because we do see many people with ADHD who have a very secure, safe home
mm-hmm,
environment. They are getting all the supports that they need. There's no trauma or anything like that, and they have executive functioning difficulty, and
mm-hmm,
they're not coming from a traumatic experience. So yeah, it's both and.
mm-hmm, right.
Yeah.
Yeah, it was funny because I feel like I noticed as I got into grad school with my anxiety, and I think it had a lot to do with like self worth and belief that I could do things, um, and that as I the more I worked on my self image and anxiety, that started to help with being able to focus. It was that my focus was very highly tied to my emotional state. I guess what I'm trying to say. And
Mm-hmm.
the better emotional state I had, the better I was able to focus. Um, but I think,
Right.
and I've already kind of talked about my story and
Mm-hmm.
the awakening and the mania and the spiritual emergencies we talked about with Jan Holden. Um,
Right.
and then I was diagnosed with bipolar, and then I was on meds. I think after that experience, my brain slowed down a lot. And after I got off of meds for bipolar, I've never been on meds again, so I haven't been on Adderall. And
Yeah.
I still I still definitely see some ADHD traits, and it's still maybe not the easiest thing for me. I am a lot more organized now. I feel like my brain is slowed down, a lot less anxiety, and my self image is better. And so I don't necessarily think of myself as like ADHD and that
Mm-hmm.
it's the same as when I was younger. So I don't know.
Yeah. Yeah.
How I kind of see it to me is like I believe you, and I agree that people can be born with ADHD and the certain executive function issues, but I think that we can do things and not just find ways of coping, but also ways of improving to where maybe that diagnosis doesn't fit, or maybe it fits less. And so there's a range of, I think that mental illness, the way the language sometimes can be off, and that it's like, hey, if you have this mental illness, we'll just try to get you to baseline health, and that's the best we can
Mm-hmm.
hope for. But it's like, I think we can also thrive and so it's a wide spectrum which we have the capability of operating in. And then also, like, if something life gets hard, then maybe we like fall back into that. So yeah.
Yeah. Yeah. No, 100%. And I think that is one of the things that we do when we're have a patient come in and they're trying to figure out, why am I struggling with my daily living, right? I'm really struggling to navigate my life. There's an overlap of a lot of conditions that, I mean, any mental health condition is going to really lead to executive dysfunction. That's why you're coming in to figure out what's happening. It's because you're having difficulty planning out your daily life, or critical thinking, or, managing all of these things that you have to manage. So when we look at it, we're looking at, is this depression? Is this anxiety? Is this ADHD? Is this PTSD? Is this bipolar disorder? Is this, so we're trying to really differentiate, which is, what we call it, a differential diagnosis, is like, we're
Mm-hmm.
trying to really untangle a lot of these symptoms into something that can most match what you're telling me your experience is.
Mm-hmm.
So it might not be perfect, it might not be um, the best explanation for your experience from your perspective, but it's the best one we have with the literature that we have, and with the manual that we have.
Mm-hmm.
And the goal is that we don't want the patient to necessarily identify with this diagnosis.
Mm-hmm. Like
We
that's their
want
identity.
them,
That's who they
like, that's
are.
their idea, like,
Right.
I am a person who's XYZ. What we
Mm-hmm.
want to say is, we want to affirm their experience and say, okay, yeah, it looks like, based on what you're telling me, you're experiencing some depression, and let's
Mm-hmm.
work through where we think that's coming from, and then that's when we can start to work through the biology, which was where medication will come in, work through their environment, in the, they're experiencing in their environment, and then work through their thinking, which is what we will do in talk therapy, right?
Mm-hmm.
We might do
Mm-hmm.
cognitive behavioral therapy or psychodynamic therapy, however you want to do that. But the goal is to try to figure out, what is it that's kind of leading to this thing. So I would say the diagnosis part is really just the start of trying to understand what this person is experiencing. It doesn't even tell the story of what's happening or why it's happening or
Right.
anything like
Mhm.
that. Yeah.
Yeah, I think it's funny we've seen the swing of extremes as far as like,
Yeah.
the older population having a stigma about mental illness and not wanting to um delve into that or be diagnosed with that or anything like that. Just think it's crazy. And then we see the opposite side, Gen Z is kind of getting into the pop culture of it and
Mhm.
like wanting to be diagnosed, but also maybe not understanding it or diagnosing with
Yeah.
it or seeing that as their identity.
And I think there are people who are rightfully concerned about the fact that we are, I think, moving into a place where we are, you know, pathologizing
Right. That's what
typical
I'm looking
human
for. Hmm.
experiences, where it's like, yeah, I'm sorry, puberty is uncomfortable. It's, I don't know a single human that goes through puberty that doesn't have anxiety, right?
Hmm.
Or, you know, retiring, life changes, going through divorce, experiencing a death, um, having people ending a friendship,
Hmm.
these are all human experiences that are hard, being disappointed. And I think that our tolerance towards distress feels as if it has really lessened. We, in our
Hmm.
effort to acknowledge that these things are painful, we've almost decreased our ability to handle the pain in a lot of ways.
Hmm.
Um, and I think part of that is, I don't think that that applies globally. I think
Hmm.
that tends to be more, a Western experience, especially here in the
Hmm.
United States. For the most part, we're not exposed to suffering to the same degree as people around the globe. And
Hmm.
so, we're not seeing death around us all the time. We're not seeing like excessive extreme illness and poverty and, things like to the degree that they are in other parts of the
Right.
world. And
Yeah.
so our tolerance for those things is a lot lower
Hmm.
than, probably a lot of people across the globe where, uh, I think we're trying to figure out how to honor the fact that, yeah, it's hard to be human. Also, we don't want to say that being human is a psychological, mental health disorder.
Right. I think,
Yeah.
and just a theory of thinking about it. Um, I think we're not experiencing those things as much as you could say as other countries, perhaps. But we're exposed to that, so we see it on TV or on
Mm-hmm.
movies or different things, and so and we see it a lot. I think we're inundated with technology, and so I think
Yeah.
maybe actually the secondhand exposure, in a way, might be worse for our health. That we're not getting the how do you say it, the benefits of actually going through that and getting the nuggets of the benefits or the strength, the
Yeah.
mental fortitude, emotional fortitude. Um, and so we just see those things and it's affecting us. And so it's actually affecting us in a worse way, perhaps
Yeah.
in that respect. Not that, going through those things would be very, very hard. And so I'm not trying to diminish that at all, but that's
Right.
just, what do you
Right.
think about that?
Well, I think, yeah, I think when you're walking through something difficult, you have time to really turn that experience into wisdom, right?
Mm-hmm.
And you've kind of carried, for lack of a better way of saying it, from a Christian perspective, it's like you're carrying the cross, right?
Mm.
You're the one who's like carrying this burden, walking through it, walking through the fire, and you get to figure out who you are in that. That's where your character really shows through. It's like, am I gonna quit? Am I gonna keep going? Am I gonna learn from the what's gonna happen? We don't know. It's a mystery. We don't know how I'm gonna handle this. But when we're just on social media and we're just witnessing horrific things, and then we shut it off, well, now we're just leaving our mind to come up with whatever kind of story it wants to come up with. It can almost be like we're experiencing this heightened arousal and cortisol, and we can't do anything with it because there's nothing to run away from. We're in our living room, or we're like, it's not like we're in the situation where we're having to engage in some kind of action. And so, yeah, I think that has a significant impact on our nervous system and on our ability to feel peace and on our ability to navigate our stressors in a way that is healthy. When you think about it, like, we haven't evolved a brain to take in the amount of information that we take in. Like, we live, we are now a global culture. We're connected globally, and there's never been a time in humanity that we've been connected globally. It's always been small areas, small tribes, small communities, but now we really are connected globally. And I think that creates a lot of discomfort for people who really want certainty. Like, I want to be able to predict what's going to happen. I want to be able to know how somebody's going to behave. I want to be able to make assessments about my safety. And if I'm connected to cultures all around the world, people all around the world, experiences all around the world, I can't predict anything. Because
and also, like, beliefs are different or in language. So yeah, feel more defensive.
So there's no groundedness, right? There's a difficulty with feeling grounded. And so I think what we see a lot of times is when chaos is really high or when people feel out of control, you tend to see a lot of cults increase or conspiracy theories. People start to engage in like these more fantastical
polarization, more the extreme views of the other side.
Of the other side, yeah. And it really it's grasping at certainty of being able to predict what's going to happen, being able to and that makes them feel grounded, but it's an illusion, as you know, right? So I think that it's multifaceted, but I think for people who have serious mental health conditions, who really do need these diagnoses, who do need the medication, we're doing them a disservice by pathologizing typical human discomfort. Because if we kind of go back to nothing is a problem, if we say there's no mental illness, that it's all environment, that the reason these illnesses occur is simply because of the capitalistic society that we've created, where people are expected to work ridiculous hours. Those are all true. Absolutely. I think the society we've created is not a thriving, for place where human psychology can thrive. But I also think that there are people who are not in that experience. They're not grounded to that reality, and they need help at least grounding to that reality.
Yeah, I agree with you. I think, there can be critics can say, and I think they have some points, that the psychology is so focused on the individual that they ignore the cultural. And you could put this in the DSM too, that what I learned about the DSM is that a lot of times we see why someone would be diagnosed with a mental illness is they meet this certain amount of symptoms, but are people looking at the root of these symptoms? Like, where are they coming from? Do they just have a crazy traumatic experience, and maybe they're experiencing these symptoms because of this experience, and it's totally a normal thing. Um,
Yeah.
but again, it can go the opposite way too, like you're saying.
Yeah. Well, and I think it's important to recognize the goal of the DSM, right? There are some people who, absolutely want a particular diagnosis. They're like, I really want to get this diagnosis. And it's like, okay, what is your goal?
Mm-hmm.
What is this diagnosis? What are you looking for? Are you looking for treatment? Are you looking for support? Are you looking like you just feel like you have been different and you want an
Mm-hmm.
answer for that and you feel like this is the answer?
Mm-hmm.
Um,
And some people maybe
so
even use that as a way of an excuse to not do something
yeah,
or do the work.
right. Everybody has a different goal for why they
Mm-hmm.
want, if somebody comes in, they want a diagnosis or they want to get evaluated. I'm always like, what brought you in? Like,
Mm-hmm.
what is your goal with this assessment?
Mm-hmm.
What are you hoping to learn or what are you hoping to understand about yourself? And so it's really important to understand the goal of the patient, right, and their experience. And for many people, getting the diagnosis is life-changing for them. It's like, man, I've
Mm-hmm.
gone my whole life never understanding
Mm-hmm.
like why I have this experience. And now I have language that can
Right.
explain it.
Yeah. I remember
Um,
when I got diagnosed, and it felt like that, like, oh, I see what's happening or what's going on. And also it's like other people going through the same thing and they have the same issues. And so it's a camaraderie as well. But also I think the biggest thing is, okay, now that I have this diagnosis, what is the research? What is the techniques to deal with this? And that's what's most important and what's most helpful.
yeah.
But over time, I did feel like I don't want to, I guess, just immerse myself in this whole ADHD world to the extent that
Hmm.
I pathologize myself, and I'm like, oh, I'm just ADHD, so now I can't do this, and then
Right.
actually holds me back. So it's kind of like personality tests. It's like,
It,
oh, there's some labels, there's some I can be put in this box, and it's helpful, and it does help me understand myself. But also, I'm not just these; I'm more, and I can also grow to be more than that. So you don't want to get
mhm.
stuck there either.
Right. And I think that's really the important piece. I think all the clinicians that I know, all the doctors I know, really try to impart that wisdom onto the patients of this doesn't define you. This isn't
Mm-hmm.
who you are. This is simply just giving you a name and some language to describe some of the experiences that you have. And so you might improve your condition to the point where maybe you're only having 3 of these experiences now instead of 8. You might improve it to where you're not having that many, right? Maybe you have a period where you've found something that works for you and you're not experiencing these experiences in a negative as you were before. So
Mm-hmm.
if you were to come in again and tell me your symptoms, I wouldn't diagnose you with anxiety
Mm-hmm.
because now you have it under control. But it's a matter of helping the patient to understand that their diagnosis doesn't define them, right? And like you said, some of that is just dependent on the individual patient and how they are going to receive that information and how that information is meaningful to them. It's just very unique to each
Mm-hmm.
individual
All
person.
right.
I think like my job's different because I do clinical assessment, so my job is to diagnose. But I think for a lot of counselors, a lot of my friends who are LPCs or counselors, many of them don't even need to tell their patients what they're billing in terms of their
Mm-hmm.
diagnosis.
Do you want
Like
to talk
if
a
the
little bit about that? I don't think we've
yeah,
gone into that, like how that all works.
sure, like how the diagnosing works.
Right. And
Yeah,
just the tie in with the insurance and stuff like that.
yeah, absolutely. So if a patient comes in, for example, to just for psychotherapy, in order for insurance to cover that, we have to give them a code, a billing code, and the billing code is based on the DSM, the
Right.
manual
So they
for
have to
mental
be
health.
diagnosed with a mental.
Yeah, so it
Yeah.
doesn't matter if you're going for therapy and you're using your insurance, we have to send the insurance something to justify the insurance paying for your therapy.
Mm-hmm.
And for that reason, there's many therapists who feel like that's unethical to just
Mm-hmm.
give somebody a diagnosis on their first appointment. And so for many of them, they don't take therapy
Mm-hmm.
because they don't
Take
want to put
insurance.
label. Yeah, or take insurance. Yeah, because they don't want to label patients with a mental health condition when patients are just coming in to get help with navigating their daily life of being human. And so for many of them, they will tell their patients like, hey, this is for insurance. You are experiencing a typical range of anxiety for
Mm-hmm.
this experience that you're
Mm-hmm.
having. For example, you're
Mm-hmm.
having grief, right? And so luckily for that reason, we do have billing codes in the manual for like adjustment disorder. And I think a lot of the patients will just be given an adjustment disorder, which is it's only going to last 6 months and you're just adjusting to something in your life right now and it's giving you anxiety and we're trying to work through that. But it is frustrating for the mental health clinicians who don't want to give everyday humans mental health
Mm-hmm.
conditions
Mm-hmm.
because it takes away from the people who have real serious, mental health
Mm-hmm.
disorders.
Right. Kind of waters it
Uh,
down.
Waters it down, and I think it just pathologizes again,
Mm-hmm.
a typical human experience. So there's
Mm.
a lot of criticism right now because the DSM was just updated and they added grief, prolonged grief,
Right.
as a
Mm-hmm.
disorder, and so there's a lot of people who are upset about that. How are you going to
What
pathologize
is a
grief?
typical? What's the appropriate amount of time for grief?
Yeah,
Like there's a
and
standard.
right. And they found that for the people who have prolonged grief, a lot of times it's a child has passed away, which you would expect that would lead to a prolonged grief, or their significant other, right? So these are things that are typical. You would expect somebody would struggle with that for a long time. And so, yeah. So, and then for me as a psychologist, people come in and they want to get a testing done to determine what is actually going on. So maybe they've tried a bunch of medications, maybe they've been to therapy a whole bunch of times. There's a lot going on, a lot of symptoms, and they're not quite sure what the name of their symptom expression is because it is so overlapped with a lot of other conditions. And so they come to me and we try to give them some psychological testing. We try to untangle all of these symptoms to try to come up with a clear picture of what's happening and give them a diagnosis, a definitive diagnosis, so that they can take that and try to get, therapy based on that diagnosis or get medication based on that diagnosis. And so for me, I do have to use, obviously use the manual to be
Mm-hmm.
able to give them a definitive diagnosis and to be able to
Mm-hmm.
look at all of their symptoms and untangle them and figure that out. So that's kind of how that works with
Mm-hmm.
diagnosing and just your everyday therapy. I
Mm-hmm.
think most people who are going to therapy, though, are just humans trying to learn coping skills,
Mm-hmm.
trying to learn a little bit about their emotional experience. Most of them don't really have pathology, even though they're being diagnosed with
Mm-hmm.
pathology. Yeah.
Mm-hmm. Yeah, it's good. I read a stat that says that 80% of meds are given by physicians, not even psychiatrists, not
Yeah.
even psychologists, but doctors, and they might not really have much actual training about that.
Yeah. I am not a medical doctor, obviously. I'm a psychologist, but I do know that, yes, a lot of medical doctors do prescribe antidepressants. I think antidepressants is one of the most commonly prescribed medications by medical doctors. Um, you know, I don't know. My thoughts on that. Um, if it were me, I would prefer to go to a psychiatrist.
Mm-hmm.
I also recognize that there's some privilege involved with accessing a psychiatrist.
Mm.
It can be very difficult to get access to a psychiatrist. One, there's just like not enough. So
Mm-hmm.
even to get access to one, you're waiting months upon months upon months. And then, you know, for people who are in marginalized communities, low socioeconomic status communities, they really are not going to have a lot of access to getting specialized care. And so
Mm-hmm.
their medical doctors are going to be, their primary care
Mm-hmm.
doctors are going to be the
Mm-hmm.
best route for them to be able to get access. So while I don't think it's ideal that medical doctors who
Mm-hmm.
maybe don't have a lot of time in that particular wheelhouse learning about those meds, I think it's the best route that we have right now for meeting our most, marginalized communities and communities that need access to care, who might need, antidepressants or
Mm-hmm.
help with anxiety. So it's complicated, but you're right.
Mm-hmm.
I think we would all be better off if we could see psychiatrists who that's
Mm-hmm.
their wheelhouse, right? They're
Yeah.
experts
Well,
in
even
navigating those meds.
psychiatrists, you know, I don't want to be extreme or polarized, or
Yeah.
but I think big pharma is a thing, and that even psychiatrists are kind of tied up in that, and so I just, I guess what I would say is just have caution
Mm-hmm.
about I think meds are, they can be great, and if you need them, go for them. I would say, if you can find alternate ways, natural ways of dealing with things, then try that first, and
Yeah.
then go the med route if needed.
Yeah. Well, and I think that's the thing. I think a lot of people, just humans in general, we want the path of, least resistance.
Eases, yeah.
We really don't want to work hard. I mean, I don't want to work hard, right? Like
Right.
I
uh-huh.
want to be lazy. I don't want to have
Uh-huh.
to get up and work out. I don't want to
Mm-hmm.
have to, do X, Y, and Z. That's normal. Um, so anytime I have a patient that I am diagnosing or working with, I always tell them, I want you to think about your medication as your life raft or your support.
Mm-hmm.
So you need to still paddle. Like you need to still, try to learn coping skills. You still need to engage in psychotherapy. And we know that with all the research shows that like the best outcomes are usually if you're doing psychotherapy with your meds,
Right,
but
yeah.
there are many people who want to say, oh, I have depression, like just give me the medication and I'll be
Mm-hmm.
good to go. And we know that the outcome for that is, like you said, 50% of people do well, 50% of
Mm-hmm.
people don't really have a positive experience. So if, medication really is supposed to be a support, part of your support system. And that
Mm-hmm.
system means it's called a system because it's more than one thing, right? So it should
Mm-hmm.
include like looking at your environment, looking at your daily habits, looking at your psychology, doing the work that's going to help improve your daily living. And the medication can help you get those behaviors happening on a regular routine. So for example, for ADHD, like Adderall's not going to help me like pay my bills. Like I still have to like use a calendar. I still have to use timers. I still have to set expectations for
Mm-hmm.
myself to practice increasing my neurotransmitters on my own. So the medication helps me get in the gym every day. It helps me to keep track of my calendar. It helps me to make sure I'm not just eating like cereal every day, that I'm like going grocery shopping,
Mm-hmm.
the medication on its own, it will help, but it's not going to help you as well as engaging in the behaviors and in doing the deep work of understanding yourself better.
Mm. Yeah, that's good.
Yeah. Yeah.
Yeah,
So,
we've covered a lot. Is there areas you think we've missed? Do you have some more to say?
yeah, I think one of the things we talked about before the call, I guess I'll just kind of finish with this,
Mm-hmm.
is that when we're thinking about mental health conditions and big pharma and systems, right? Psychology is
Mm-hmm.
focused on individual people, but we work in a system that is geared towards the population, not individual people. And that's just out of necessity because we have to have a framework in order to be able to meet the most amount of people as possible. And so, unfortunately, within that framework, we're working based on statistics that capture the norm, which is about 70% of the population. And that means that 30% of people are not going to fall within that range of experiences. And so the goal is to recognize that every clinician is doing the best that they can to try to meet people where they're at. And if you feel like you're not being understood or the medication isn't working or you don't fit within that average range, then that's a really good sign to, talk to your doctor or find a new doctor or find a new therapist. But you are your greatest advocate. Doctors are limited in what they can and cannot do, and that's based on insurance companies and just the number of people that they have to see. But I know that for the most part, nobody gets into this field with the goal of harming anybody or ignoring people. Everybody wants to meet people where they're at, but ultimately, you are your biggest advocate. So you have to get in tune with what you need and really work on how to communicate that. And if you're not sure how to communicate that, that's a great place to start with your therapist, is how do I communicate to my doctor that I'm not happy?
Mm.
Yeah. So
yeah,
I will,
that's great.
I guess that's a good place to end.
Yeah. Thank you so much for all your wisdom and knowledge and stuff like that. I appreciate it.
Yeah, no problem. Thanks for having me again, Kendall.